Welcome everyone. In this video we shall be talking about congenital heart disease. In this part we shall be talking about the acyanotic ones, acyanotic diseases like VSD, ASD, PDA and coarctation of aorta. We shall be talking about these four diseases in this video, and in the next part we shall be talking about the cyanotic ones. Okay. So moving on to the first question. Which of the following? Which of the following are a part of NADA's minor criteria? Right. Remember that these NADA's criteria is for screening of congenital heart disease. Right. NADA's criteria is for screening of congenital heart disease. Now NADA's criteria is two parts. Right. If we talk about NADA's criteria, it has two components: the major components and the minor components. Right. Excuse me. Under major components, we have a systolic murmur. We have a systolic murmur of grade more than equal to 3 of 6. We have diastolic murmur. We have diastolic murmur of any grade. We have cyanosis. We have associated congestive cardiac failure. These four are among the major criteria of NADA. And under minor criteria, number 1, we have the systolic murmur, right, grade less than 3 of 6. And we have abnormal, we got abnormal CVS findings. These abnormal CVS findings can be in the form of, just a second. These abnormal CVS findings can be in the form of an abnormal S2, abnormal blood pressure, abnormal chest X-ray, or an abnormal ECG. Okay. Now remember when to suspect, right? When to suspect a congenital heart disease, right? When one major or two minor criteria are present. Okay. Now the question says which of the following are a part of the minor criteria? Grade 2 systolic murmur, yes, less than 3. This is minor criteria. Diastolic murmur, any grade would be major. Cyanosis would be major. Abnormal second heart sound would be minor. So our answer over here would be option B, A and D. So this NADA's criteria is quite important, especially from the INI point of view. This question has been like repeated 2-3 times in INI. Okay. Moving on to the next question. Now, a 2-week-old neonate is diagnosed with the most common type of ventricular septal defect. Now, the defect is located in the area of interventricular septum, that is last to form and lacks the muscular tissue. Which specific anatomical region is involved? Now, we are talking about VSD. Remember that on the basis of location, VSD can be divided into 4 types. On the basis of location, it can be divided into 4 types. First, we have the membranous type. On the membrane, right? This is the most common type and is the first one to get formed. Okay. Next, we have the muscular type. Muscular type is the first to form. Whereas membranous type, membranous is last to form. Membranous interventricular septum is last to form, whereas muscular part is the first to form. Right. Then we have the inlet type. The inlet type is near the AV valves, near the atrioventricular valves, right? That's why it has associated with involvement of the mitral valve, and that can lead to development of mitral regurgitation. It can be associated with mitral regurgitation. And finally, we have the outlet type. We have the outlet type or the supracrystal type. Outlet type or the supracrystal type, right over here. Now this is actually associated with the involvement of the right cusp of the aortic valve, right? The right aortic cusp. As a result of which we would get aortic regurgitation. We might get aortic regurgitation in the outlet variety. Inlet outlet variety are quite rare. The most common among them is the membranous one. Okay. So they asked us about the most common type and the one that forms last and lacks muscular tissue. So our answer over here would be option D. Okay. Moving on to the next question. Now regarding the hemodynamics of a large VSD, which of the following structures undergoes the least amount of volume overload in early stages of the disease? Now the pathophysiology of all these things are quite important, right? Now let's have a look into the pathophysiology of a VSD. What happens in VSD? There is a shunt from left ventricle. There is a shunt of blood from left ventricle to the right ventricle via the ventricular septal defect. Okay. and from the right ventricle the blood is pumped to the pulmonary artery, from the pulmonary artery to the lungs, from the lungs to the left atrium, to the left atrium, left atrium to the left ventricle. This is what happens, right? Now this shunt that is occurring, this shunt occurs during systole. Okay. Now during systole an extra amount of blood is being presented to the right ventricle, but what happens is that both the ventricles contract at the same time. So when left ventricle contracts to shunt the blood, the right ventricle is also contracting, so it will directly direct the blood to the pulmonary artery, right? So the blood from the left ventricle shunts directly to the pulmonary artery via the right ventricle, which means that the blood does not get accumulated in the right ventricle because it is transferred to the pulmonary artery, okay, because it is occurring during systole, as a result of which volume overload state is not reached by this right ventricle, at least in the initial stages, okay. And the question asked us about the one that undergoes the least amount of volume overload in the early stages of the disease. That's why your answer would be right ventricle. This is because the right and the left ventricle are contracting at the same time. So the blood directly from the left ventricle via the right ventricle goes to the pulmonary artery. Okay. So the last one to get affected is right ventricle. Okay. Moving on to the next question. Now, a 25-year-old male with a history of an untreated VSD presents with cyanosis and clubbing. On examination, the previously loud holosystolic murmur is now barely audible, but there is a loud P2 and palpable pulmonary impulse. What is the most likely pathophysiological change? Okay. What happens over here? Again, we have this left ventricle, and via the VSD, the blood is being shunted to the right ventricle. Okay. Now, this is occurring during systole. As a result of which we get a holosystolic murmur. A holosystolic murmur is associated with this transfer, with this shunt. But it has been mentioned that the previously loud holosystolic murmur is now barely audible. Now this shunt murmur is decreasing, right? This shunt murmur is decreasing. Okay. This shunt murmur is decreasing. What is the significance? This means that the pressure in right ventricle is becoming equal to that of the left ventricle. Okay. Pressure in the right ventricle is becoming equal to that of the left ventricle, which is restricting the shunt. Now we all know that blood from left ventricle flows to the right ventricle and from right ventricle to the pulmonary artery in VSD. Now with this chronic transfer, with this chronic shunting, there is pulmonary vascular remodeling. Which results in development of pulmonary hypertension. And this pulmonary hypertension increases the right ventricular pressure, right? And with time, this right ventricular pressure becomes equal to left ventricle, and at that point, when it becomes equal, this murmur disappears. Okay, because there is no flow. Now again, with progress, the pressure in right ventricle surpasses left ventricle. Okay, there is further deterioration of the disease. Now what happens? Now the blood from right ventricle passes to the left ventricle. That is deoxygenated blood to the left ventricle. This would result in development of cyanosis. This whole thing that we discussed, this whole thing is known as Eisenmengerization or Eisenmenger syndrome. Okay. That an acyanotic heart disease is converting into cyanotic heart disease due to pulmonary remodeling with the development of pulmonary hypertension. Okay. This is a very important concept. So it becomes okay. Now we know this loud P2 is due to pulmonary hypertension, and this palpable pulmonary impulse is due to right ventricular hypertrophy. Now we all know why the things are occurring, why the cyanosis is present. Okay. Now what is the most likely pathophysiological change? Yes, it is due to pulmonary vascular resistance has exceeded systemic resistance. Okay. If we look into the other options, development of infective endocarditis, no. It is not due to infective endocarditis, but something important about endocarditis, infective endocarditis. Remember that it is the most common complication in VSD, right? And it's caused by strep viridans. Okay. Spontaneous closure of VSD would lead to abolishment, would abolish the murmur, but it won't lead to development of pulmonary hypertension. We won't get loud P2 and palpable pulmonary impulse. An acquired infundibular pulmonary stenosis, this is a characteristic finding of TOF, tetralogy of Fallot, which we will be talking in the next video. Okay, over here answer should be option C, and this is the pathophysiology of Eisenmenger syndrome. Okay. Moving on to the next question. Match the following clinical findings in VSD with their underlying cause. Over here we need to understand the murmurs associated with VSD. What happens? Again we will move back to this thing, left ventricle to the right ventricle shunt via the VSD, and we have already discussed we get a holosystolic murmur. Why? Because the blood shunts only during the systole. Okay. Now from the right ventricle to the pulmonary artery, from the pulmonary artery to the lungs, and from the lungs to the left atrium, from the left atrium to the left ventricle. This is how the blood is flowing, right? So an increased amount of blood is being presented to the right ventricle, but the right ventricle is also shunting it to the pulmonary artery. So an increased amount of blood flows through the pulmonary valve. This is the pulmonary valve. From the right ventricle to the pulmonary artery, we have the pulmonary valve. So increased amount of blood is flowing through this pulmonary valve. So over here we get a flow murmur. Over here we get a flow murmur, which would be an ejection systolic murmur. Okay. Now increased amount of blood to the pulmonary artery, to the lungs, to the left atrium, to the left ventricle. The increased amount of blood is now passing from left atrium to the left ventricle as well. Right over here, this is the mitral valve. This is the mitral valve. Right, an increased flow. So over here also we would get a flow murmur, and this time it would be a mid diastolic murmur. This would be a mid diastolic murmur. Okay. So these are the two flow murmurs that are associated, one through the pulmonary valve, another through the mitral valve, besides the holosystolic murmur. Now if we look into the option, holosystolic murmur is due to the turbulence across VSD, we know this. Mid diastolic murmur would be due to the mitral valve involvement, increased mitral flow. Loud P2 is due to pulmonary hypertension, and ejection systolic murmur due to increased pulmonary flow. Okay, these flow murmurs are important. Okay, so the answer would be A1, B2, C3, D4. Option A should be your answer. Okay, moving on to the next question. Now, a 4-month-old infant with a large VSD and failure to thrive is being considered for surgery. Right? Which of the following is an absolute contraindication to surgical closure of the defect? Now, before we answer this question, let's have a look into the surgical closure of VSD. Now, the surgical closure of VSD can be done via two means, either via a Dacron patch, or an occluder device, or we can use an occluder device. Okay. Now, if we talk about the indications, remember that there are 3 indications to VSD surgery and 1 contraindication to VSD surgery. Right, indication is presence of congestive cardiac failure. Second is QP to QS ratio of more than 2. What is meant by this? QP means pulmonary flow, QS means systemic flow. If the systemic flow is a pulmonary flow to the systemic flow ratio is more than 2, that is an indication to perform surgery. And if we get an outlet variety or a Swiss cheese muscular variety. What is the Swiss cheese muscular variety? Over here we get multiple defects. Like a Swiss cheese, like the Tom and Jerry wala cheese, right? We get multiple defects. So these are the 3 indications to perform surgery in VSD. Whereas we have got only 1 contraindication, that is Eisenmenger syndrome. Once pulmonary hypertension develops, once Eisenmenger syndrome develops, right, there is no role of performing a surgery. It won't improve the situation. Okay. So they asked us about absolute contraindication, net right to left shunt with a PVR more than 8 Wood units. This would be our answer. Right to left shunt is nothing but our Eisenmenger syndrome, and PVR more than 8 Wood units means pulmonary hypertension, right? More than 3 Wood units is pulmonary hypertension. So over here it is more than 8. So if we perform a surgery, this would rather worsen. This would precipitate right heart failure. Okay. QP to QS ratio of 2.5. Yes, this is an indication. Age less than 6 months. Yes, we should go for early surgery, right? It should be done before 6 months of age. Okay. And multiple Swiss cheese muscular VSD. This is also an indication. Okay. Now if it, just a second, okay. Now moving on to the next question. Right, regarding the management of VSD, which of the following statements are true? Most small muscular VSDs close spontaneously within the first 2 years of life. Yes, this is a true statement, right? This is except the Swiss cheese one, except the Swiss cheese pattern, except the Swiss cheese variety, right? We discussed that, right? Because that is an indication of surgery, because that rarely closes spontaneously. Digoxin and diuretics are used to manage heart failure symptoms. Digoxin and diuretics are used to manage heart failure symptoms while awaiting surgery. Yes, this is a true statement. We can also add AC inhibitors. Okay. Infective endocarditis prophylaxis is now recommended for all patients with isolated VSD. No, this is a false statement. This prophylaxis is not for all the patients. Remember that infective endocarditis prophylaxis would be used in 3 conditions. Once it is if it is associated with cyanosis, that is if Eisenmenger syndrome is present, if associated prosthetic valve is present, and if there is a history of infective endocarditis, previous infective endocarditis is present. These are the 3 conditions where we would go for prophylaxis, otherwise not. Okay. A pulmonary artery band is definitive treatment for all large VSDs. This is again a false statement. This pulmonary artery band is actually a palliative measure, and not at all definitive. Right. This can be done in cases where surgery is difficult. Right. One is Swiss cheese variety, or in very small neonates and very small infants, or in neonates. Right. Or when associated with complex congenital heart disease. In those conditions, we can go for a pulmonary artery band. Okay. So our answer over here would be only A and B. So option B should be our answer. Okay. Moving on to the next question. Just a second. Extremely sorry for the cut. Let's continue with our discussion. Right. A 4-year-old child presents with a grade 2 of 6 systolic murmur at the left upper sternal border and a fixed split S2. ECG shows a left axis deviation and a prolonged PR interval. Which embryological defect is responsible? Remember, whenever we are getting a low grade systolic murmur in the left upper sternal border, with a fixed split S2, now this is almost always diagnostic of an ASD. Okay, atrial septal defect. Fixed split S2, low grade systolic murmur in the left upper sternal border, that is ASD. Okay. Now we need to answer which exact type. Now, so these all four options are types of ASD. Now, something important that we need to know, that this ostium secundum is associated with a right axis deviation, whereas this ostium primum is associated with left axis deviation, or sometimes with a first degree heart block. Right? Just remember it as a fact. Ostium secundum is right axis deviation, ostium primum left axis deviation. Okay. And it has been mentioned, and left axis deviation is present with a prolonged PR interval, that is first degree heart block. So we can easily say our answer over here should be ostium primum. But if we talk about each of these four, remember ostium primum defect is associated with mitral valve involvement. So we can get mitral regurgitation or mitral valve prolapse with ostium primum defect. Whereas ostium secundum defect is the most common ASD, is the most common variety of ASD. Ostium secundum defect is the most common variety, Okay. And if we talk about these two are extremely rare varieties. Coronary sinus defects means there is a connection between the left atrium and the coronary sinus. Whereas in sinus venosus, there is a connection between right atrium and the SVC. Okay, these are extremely rare. These two are not important. Okay. Ostium primum and secundum, how to differentiate on the basis of ECG, right axis deviation or left axis deviation, right? Ostium secundum associated with right axis deviation, primum associated with left axis deviation. Okay. Moving on to the next question. Match the following clinical findings in ASD with their underlying cause. Now again, you need to know the complete pathophysiology of ASD. Now in ASD, what happens? Just a second, guys. In ASD, what happens? Now the flow or the shunt is from left atrium to the right atrium. Okay. This is via ASD. Okay. Over here, remember that over here what happens? over here the pressure difference is very low in the atria, because the atria are low pressure units, right? Over here the pressure difference is low. That's why the shunt murmur over here is absent. The shunt murmur that used to be present in VSD is absent over here. Now what happens? From the right atrium, the blood will be pumped to the right ventricle, from the right ventricle to the pulmonary artery, from the pulmonary artery to the lungs, and from the lungs to the right atrium, left atrium, from the left atrium to the left ventricle. Now an increased amount of blood is presented to the right atrium, So increased amount will flow from right atrium to right ventricle via the tricuspid valve, So over here we would get a flow murmur, and this would be a diastolic, flow murmur, Similarly, an increased amount of blood will flow from right ventricle to the pulmonary artery via the pulmonary valve. So again we would get a systolic flow murmur, via the pulmonary valve. Now if we look into the options, if we look into the table, mid-systolic murmur at left upper sternal border, that is due to increased flow across the pulmonary valve, and mid-diastolic murmur at the left lower sternal border, that is due to tricuspid valve. Okay. Pulsatile liver is due to the right heart failure, right? With time, of course, when increased amount of blood is presented to right atrium and right ventricle, the right ventricles are going to go into failure. Due to right heart failure, there will be backflow and we would get a pulsatile liver. So this is also pulsatile liver due to right heart failure. Now we need to talk about this fixed split S2. Again, sorry for the cut. Right, we shall be discussing about this fixed split S2. Now this is quite important, right? This fixed split S2. Now before we talk about this fixed split S2, let's talk about this S2, right? Normal. In a normal individual, what happens? S2 comprises of two components, right? We have a A2 component, we have a P2 component, right? That is the aortic valve, closure of aortic valve and the closure of the pulmonary valve. Okay. Now normally only A2 precedes P2. There's a very little time difference, but normally A2 precedes P2. Why? Because the left ventricle is much more powerful than the right ventricle, right? So it will transfer all the blood much before that of pulmonary valve. That's why the aortic valve closes faster than the pulmonary valve. Okay. Now we need to understand something. There is a variation with inspiration. The gap between the A2 P2 varies with inspiration. How it varies, we need to know, right? Normally in inspiration, when we inspire, what happens when we inspire? When we take a deep breath, there is increased venous return to the right ventricle. There is increased venous return to the right ventricle, and there is decreased venous return to the left ventricle. Why is it so? Because of pulmonary pooling, there will be decreased return of blood. There will be decreased return of blood to the left atrium or left ventricle, and when we inspire, increased blood from the systemic circulation comes to the right heart. Okay. Now what happens? An increased amount of blood has to be pumped by the right heart, whereas a decreased amount has to be pumped by the left heart. The left heart was already efficient enough to pump the blood faster than P2. Now it has to pump out less blood. So if we talk about this normal A2 P2, now the aortic valve will close faster because it has to pump out less blood. So this will move over here. This will be further before in time, right? Whereas more amount of blood has to be passed by the right ventricle, right? Normally the right ventricle was slow. It was slow already. Now it has to pump more blood, right? So it will be further slow. It will move over here. So the gap increases between A2 and P2. This is the normal variation that occurs with inspiration. This is completely normal, completely physiological. Okay. This is what splitting means. This is what splitting means with deep inspiration. This is normal and physiological. Now we come to ASD, right? This was nothing related to ASD. Now we come to ASD. In ASD, what happens? We all know that there is a communication between left atrium and the right atrium, right? And blood flows from left atrium to right atrium. Okay. So the blood directly, without even requirement of inspiration, there is increased amount of blood to the right atrium from the left. That is less to the left and more to the right, because left is only shunting its blood to the right. Okay. So increased amount on the right side, decreased amount on the left side. This is what was happening in split, right? Since there is decreased amount of blood in the left side, so the aortic valve are going to close much faster than pulmonary valves, right? So we would get a split, right? We would get a split. And what is meant by fixed? Fixed means it won't vary with inspiration. Now, why does this split does not vary with inspiration? What happens during inspiration? During inspiration, there is increased venous return to the right ventricle. Increased venous return to the right ventricle, and there is decreased venous return to the left ventricle. Now, whenever there is decreased venous return to the left ventricle, the blood that was returning from the lungs to the left atrium was being shunted to the right atrium. Now, the blood that is coming to the left atrium has only decreased due to this pulmonary pooling. When we are inspiring, the blood that was coming from lungs to the left atrium has decreased. Since that has decreased, the shunted blood will also decrease. So, decrease in shunt blood, right? The shunt blood is decreasing, but on the other hand, we are getting an increased return from the systemic circulation to the right heart. This increase and decrease somehow balances each other. This somehow balances each other, and we do not get the inspiratory variation. This is meant by this fixed split S2. Normally we are getting a split. Why? Because of this transfer from left atrium to right atrium. But this split is not varying with inspiration. Why? Because on inspiration less amount of blood is provided to the left atrium for shunt. That is the reason for fixed split S2. Okay. Okay, so fixed split S2 is due to constant RV stroke volume throughout respiration. Okay. So the answer would be A2, B1, C3, D4. A2, B1, C3, D4 option C should be our answer. Okay. This is the pathophysiology of our ASD. Moving on to the next question. Now, a 55-year-old female presents with progressive dyspnea. Okay. She has a known secondum ASD. On examination, previously fixed split S2 has now become single and a loud ejection click is heard. What does the single S2 signify? Again over here, there was the splitting. The splitting was due to the shunt. The splitting was due to the shunting. Okay. Now this shunting is, so split is absent, so which means the shunt has gone. How will shunt go? Right, when the right atrial and the left atrial pressure equalizes, which is due to pulmonary hypertension. Again, this is also Eisenmenger syndrome. This is also Eisenmenger syndrome. In pulmonary hypertension, what happens? There is early closure. There is early closure of P2. Right. Now, A2, P2 mein jo gap thi, the gap that we had in A2, P2, now the P2 is closing earlier. It merges with A2. That's why the split vanishes. Due to this pulmonary hypertension component. Okay. What does the single S2 signify? Development of pulmonary hypertension should be our answer. Okay. This fixed split actually gets replaced by a loud P2. Okay. This heartbeat wala, this S2 wala concept is clear. We will move on to the next question. Which of the following is an absolute requirement for considering a secondum ASD for percutaneous device closure? The patient age over 18 years, that's a false statement, right? It must be done. It must be, ASD must be corrected within 4 years of age. Okay. ASD size of less than 8 millimeters. ASD size of less than 8 millimeters. No, that's a false statement. Right, that's a false statement. Below 8 millimeters size, we do not perform surgery. A QP to QS ratio less than 2:1. This is again a false statement. B and C are actually not indications. They are not even indications for surgery. Right, forget about requirement. But adequate tissue rims are more than 5 millimeter around the defect. Yes, this is an absolute requirement, right? Because this is required for a stable device anchoring. Right? This prevents device embolization. If we talk about the indications, of surgery, in ASD, there are three indications. One, when the size of the defect is more than 8 millimeters, when QP to QS ratio similar to that of VSD is more than 2, and when there is associated congestive cardiac failure is present. Okay. Moving on to the next question. Now, 45-year-old male with an ASD present with sudden stroke. Now, he has no history of atrial fibrillation or carotid disease. Now, bubble study on echocardiography shows microbubbles crossing the left atrium within 3 cardiac cycles of injection. What is it diagnostic of? Now, male patient with ASD, no history of atrial fibrillation of carotid disease, but a stroke. This is suggestive of cardiogenic. This is suggestive of a cardioembolic stroke. Cardioembolic stroke. Now we need to decide. A bubble study has been given, right? Before we answer this question, remember the interpretation of bubble study. The right interpretation of bubble study. If we get a normally we do not get bubbles. We do not get bubbles crossing into the left atrium. But if we get, we need to check one important thing, whether it does so within 3 beats or it does after 3 beats. If we get the bubble crossing within 3 beats, this means it is an intracardiac shunt. An intracardiac shunt is present, right? Like ASD, most commonly in the form of ASD. But if it does after 3 beats, then intrapulmonary shunt is present. Intrapulmonary shunt is present in the form of pulmonary AVM, arteriovenous malformation. Okay. So now if we have a look, yes, the bubble is crossing the left atrium, crossing into the left atrium, and within 3 cycles it is crossing. So the answer should be option B, paradoxical embolism via ASD. Had it been more than 3 cycles, then our answer would have been pulmonary AVM, right? But over here, this is not an answer. Normal physiological variant, no. In normal physiological variant, the microvalves do not cross into the left atrium. Okay, and endocarditis with vegetation embolization is completely out of the picture, right? We do not require a bubble test to diagnose this. Okay. This is all about the bubble study that we need to know. Only this less than 3 beats or more than 3 beats, right? Whether it is an intracardiac or intrapulmonary shunt. Okay. Moving on to the next question. Which of the following is the primary mechanism of physiological closure of ductus arteriosus at birth? Right, remember that. What happens at birth? There is mechanical expansion of the lungs. And the pulmonary circulation begins. Okay. Now, as a result of it, 2 things occurs. Number 1, there is a decrease in PGE1. Why is the decrease? Because of the pulmonary circulation, this PGE1, accumulated PGE1 starts to get washed out. They get washed out. Right, and this PGE1 was actually responsible for maintaining the patency. Now, since it is washed out, it will lead to closure. But remember, the most important thing that is responsible for closure is actually increase in PaO2 due to expansion of the lungs and beginning of pulmonary circulation. This is the most important factor. For closure. Why? Because this increased PaO2 causes constriction of the smooth muscles, in the ductus arteriosus. Okay, and this would result in closure. And this is the most important thing. Okay, so our answer over here would be increased PaO2. Right? If not increased PaO2, then it would be decreased PGE1. Right? Not increased. Right? Increased PGE1. Then it would be decreased PGE1. And if not decreased PGE1, then our answer would be mechanical expansion of the lungs. Mechanical expansion of the lungs it's an indirect contributor. Right? Had A been not there in option, then our answer would have been decreased PGE1. Had that also been not there in option, then our answer would have been mechanical expansion of lungs. Okay. Increased systemic vascular resistance. This is after birth. This is actually secondary to cord clamping. This is due to secondary to umbilical cord clamping. Right, but it is not associated with primary closure of the ductus arteriosus. Okay. Moving on to the next question. A 28-week preterm neonate has a significant PDA. Now you decide to initiate medical closure. Which of the following is the mechanism of action of the most commonly used first-line intravenous pharmacological agent? Now, if we talk about the medical management, of PDA, we all know that PDA actually occurs due to increased PGE1. Right? We need to stop that. Right? Now, there are 2 approaches. If the patient can have enteral feed, then we can go for oral drugs. And if the patient cannot, then we would use IV drugs. Under oral drugs, we have ibuprofen as well as indomethacin. Ibuprofen is preferred to indomethacin. Okay, whereas in IV we do not have Ibuprofen, only indomethacin would be a choice, right? Why is ibuprofen preferred to indomethacin? Because indomethacin associated with an increased risk of necrotizing enterocolitis in such patients. Okay, that's why ibuprofen is preferred. But if you have to give IV drugs, then indomethacin is the only choice that we have. Now, what is indomethacin, ibuprofen? They are NSAIDs. What do NSAIDs do? They are non-selective COX inhibitors. Non-selective COX inhibitors. So our answer would be option A. Okay. Moving on to the next question. Now, regarding the clinical signs of a large PDA, which of the following peripheral signs is unlikely to be found? Right. Remember that what happens in PDA. Right. One important thing, the PDA cardiological findings will be almost similar to that of aortic regurgitation. Okay. Why is it so? Now this time the shunt is from aorta to pulmonary artery. This time the shunt is via the PDA from aorta to the pulmonary artery, from the pulmonary artery to the lungs, from the lungs to the left atrium, from the left atrium to the left ventricle to aorta. Okay. And from the left ventricle to the body as well. Okay. So what happens now? There is an increased blood supply to the pulmonary artery, and decreased supply to the body, right? It also supplies to the body, but the supply decreases over here. As a result, this PDA is responsible for the shunting of blood, and this shunt is actually more specially during diastole. The shunt is actually more during diastole. That's why the shunt is actually responsible for decrease in the diastolic blood pressure. Okay. And increased amount of blood is presented to the pulmonary artery, then to the lungs, to the left atrium, to the left ventricle. So this left ventricle gets increased amount of blood. We get increased blood flow to the left ventricle, and which is responsible for the increased systolic blood pressure. So we get a decreased diastolic blood pressure, increased systolic blood pressure. These two things are responsible for the aortic regurgitation like features. Right. Now if we move on to the options, you have Durose's sign. Durose's sign is actually, what is Durose's sign? It is murmur over femoral artery. Right. Although very much specific of aortic regurgitation, but can be seen in PDA as well. Narrow pulse pressure, increased systolic blood pressure and a decreased diastolic blood pressure. So it won't be narrow, it would be a wide pulse pressure. This is our incorrect answer. Bounding peripheral pulse due to increased systolic blood pressure, hyperdynamic apical impulse again due to increased systolic blood pressure. And answer over here would be option B. Okay, just a second. Sorry for the cut. Moving on to the next question. In which of the following scenarios closure of PDA would be contraindicated? Now, 1 day old with transposition of great vessels. What happens in transposition of great vessels? In transposition of great vessels, the aorta and the pulmonary artery are reversed. So as a result of which, the oxygenated blood circles within itself, right? Circles within lungs, and the oxygenated blood keeps on getting oxygenated. Deoxygenated blood keeps on circulating the body. Okay. As a result, but in case of TGA, for survival, a communication must be present. And that communication must be present because they are circulating in parallel to each other. They are not, the oxygenated and the deoxygenated blood are not combining. So we need a channel so that they can combine. Okay. When the PDA is present, it is actually providing the channel for mixture, right, which is keeping the patient alive. Now if we close that PDA, the patient will die. That's why it is completely contraindicated in case of transposition of great vessels, and we shall be talking about this TGA in great details in the next video in cyanotic heart disease. Now 3-day-old preterm with respiratory distress syndrome and a large PDA. What happens in a large PDA? In large PDA, there is pulmonary edema. And this will worsen respiratory distress syndrome. So we need to close PDA. So this is not a contraindication. A 5-year-old child with moderate PDA, no pulmonary hypertension, we would go for surgery. This is not a contraindication. But a 20-year-old with cyanosis and PVR more than 10 units. PVR more than 10 units means pulmonary hypertension is present. Cyanosis means Eisenmenger syndrome is present, right? Eisenmenger syndrome, pulmonary hypertension, absolute contraindications, right? Absolute contraindications. Okay. So we would This is an absolute contraindication. We would not go for surgery. So answer would be A and D. Okay. Answer should be option B. Okay. Moving on to the next question. Now, a 15-year-old female presents with machinery murmur and a differential cyanosis. Her hands are pink with a saturation of 96, but her feet are dusky and clubbed with a saturation of 84. Which of the following are true regarding the condition, right? A machinery murmur is usually seen in a PDA, right? We might see machinery murmur in some other conditions like aorticopulmonary window, then rupture of sinus of Valsalva, in AV malformation, and sometimes even in the collateral formation in coarctation of aorta. But most commonly, if we are talking about machinery murmur, it is almost always due to PDA. Okay. Now we got a PDA, but we have differential cyanosis. Differential cyanosis means Eisenmenger has occurred. Eisenmenger syndrome is present, right? Whenever we get cyanosis in an acyanotic disease, it is almost always due to Eisenmenger syndrome, right? Might be some other causes, but Eisenmenger syndrome is one of such causes, right? But in a PDA, Eisenmenger has occurred, but the hands are pink. The saturation in the hands are normal, but the feet are involved. Okay. Which means that the Eisenmengerization has occurred distal to the vessels which are supplying the hands, that is left subclavian artery. So answer over here should be option D. The PDA is distal to the origin of the left subclavian artery. That's why the supply to the hands are maintained, whereas supply to the feet are gone. Okay. If we look into the other options, right hand will also be cyanotic if the left subclavian artery is involved. Remember that this right hand is supplied by the brachiocephalic trunk. And brachiocephalic trunk is proximal to the left subclavian artery. If your left subclavian artery is involved, your left hand will be involved, but your right hand will be normal. Okay. So this is wrong. She has associated transposition of great vessels. That's a false statement. In transposition of the great vessels, we have central cyanosis, right? We won't get a differential cyanosis. Surgical closure of PDA will resolve the cyanosis. No, we have already discussed that if Eisenmenger syndrome is present, surgery is absolutely contraindicated. So this is also false. Answer should be option D. Okay. Moving on to the next question. Now a 16-year-old male is being evaluated for refractory hypertension. Right, on physical examination, there is significant radiofemoral delay. The barium swallow of the patient is shown in the image below. Which of the following blood pressure patterns is most commonly seen in this patient? So in this X-ray, we can very well appreciate this 3 sign, figure of 3 sign or E sign or reverse 3 sign, whatever you want to call it. Now this notch is due to coarctation of aorta. What happens? There is actually contraction of an ectopic ductal tissue, right, around the aorta, and this bulge over here is the dilated left subclavian artery. Okay. This is coarctation of aorta, right? Even we have radiofemoral delay. This also contributes. This also adds on to our diagnosis. We have coarctation of aorta. Now the question is that which is the most blood pressure pattern is most common. Remember that the most common site, if we talk about the most common site in coarctation of aorta, it is just distal to the left subclavian artery. It's just distal to the left subclavian artery. Even over here, just distal to the left subclavian artery, we have the coarctation. So if the left subclavian artery ke distal mein we have the coarctation, then the blood supply to the hands will be normal or rather high, whereas blood supply to the feet will be gone, right? It will be less. That's why we would get higher pressure, normal to higher pressure in the upper limbs and low pressure in the lower limbs. So high BP, uniformly high BP in all 4 limbs? No. High BP in both arms and significantly lower in both the limbs? This should be a correct answer. High BP in both legs and low BP in both arms? No. High BP in right arm, low BP in left arm and both legs. Now this can be seen in coarctation, right? This can be seen in coarctation if the coarctation is proximal to left subclavian, then we can get normal in right hand but decreased in left hand. ठीक है, but remember this is not the most common site. This is not the most common site, and the question asked us about the most common pattern. ठीक है, that's why our answer is option B. But remember the fact that option D can also be seen in a variant. ठीक है, moving on to the next question. Regarding rib notching seen in coarctation of aorta, which of the following is most accurate? What happens in rib notching? In coarctation of aorta, the blood supply is decreased. The blood supply to the lower limb is decreased, right? Now the body has to compensate. So there would be increased flow via collaterals. And what are the collaterals? You have the intercostal arteries. And these intercostal arteries run below the ribs and are responsible for this chronic increased flow through those intercostal arteries would lead to notching of the bones, notching of the inferior surface of the ribs. Okay. Now if we look into the options, is commonly seen in neonates with preductal type. No, this is a false statement. In neonates we won't get that, right? Why? Because this notching developed due to this chronic increase in blood flow. In a neonate, right, that much time has not passed कि we would get those notching. Okay. Involves only the left-sided ribs if coarctation is postductal. That's a false statement. We get bilateral notching. And occurs on the superior margin. No, that's a false statement. They occur on the inferior margin of the ribs. Occurs on the inferior margin of the 3rd to 8th rib due to dilated posterior intercostal arteries should be our correct answer. Okay. Moving on to the next question. Which of the following anomalies are strongly associated with coarctation of aorta? Now this is something factual. Yes, it is a bicuspid aortic valve is associated. This is rather the most common association with coarctation of aorta. Berry aneurysms of circular villus is also associated, and there is an increased risk of subarachnoid hemorrhage as well due to rupture. Okay. Turner syndrome, we all have read that the cardiac anomalies in Turner syndrome most common is bicuspid aortic valve followed by coarctation of aorta. You have already we know this, right? The cardiac anomalies in Turner syndrome, but VSD is not associated with excuse me, coarctation of aorta. So the answer over here should be option C, A, B and C. Okay. Moving on to the next question. Now a patient with suspected coarctation of aorta undergoes an ECG. Which finding is most likely to be present? Right, what happens in coarctation of aorta? In coarctation of aorta, there is an increased impedance. There is increased impedance to the forward flow via the aorta. Right, it is similar to that of aortic stenosis. Okay. Now what happens? There is increase. This results in an increase in pressure overload. The increase in pressure overload on left ventricles. Okay. This would result in left ventricular hypertrophy. Okay. Moreover, this increased pressure load with time will develop the strain patterns. Strain patterns would be present. This is due to the subendocardial ischemia. Due to the subendocardial ischemia, we would get the strain patterns. So now if we look into the options, left ventricular hypertrophy with ST-T wave changes, this should be our answer. This ST-T wave changes are the strain pattern. The strain pattern due to the subendocardial ischemia. Low voltage complex in all the leads are actually seen in pericardial effusion. Or it can also be seen in hypothyroidism or in obese patients, right? Delta wave seen in Wolff-Parkinson-White syndrome, and right axis deviation involved in right ventricular involvement, right? This is completely out of the picture over here, right? Answer should be option A. We get left ventricular hypertrophy with ST-T wave changes in coarctation of aorta. We might get that ECG finding. Okay. Now, moving on to the next question. Which of the following is an absolute indication for intervention in a patient with coarctation of aorta? Intervention over here means balloon angioplasty. Okay. Now, presence of bicuspid valve alone, right? Presence of bicuspid valve alone is not at all an indication. Diagnosis of Turner syndrome, again, just diagnosis of Turner syndrome is not an indication. Incidental finding of rib notching on X-ray, again, that's a chronic finding, again, not an indication. But this peak to peak pressure gradient of more than 20, yes, this is an indication. Because such a high pressure gradient is associated with complications in the form of heart failure, complications in the form of stroke, complication in the form of aortic rupture. Okay. That's why whenever the pressure gradient is so much, we would go for a surgery, mostly in the form of balloon angioplasty. Okay. With this question, we come to the end of our discussion of this long video on acyanotic congenital heart disease. In the next video, we shall be talking about the congenital heart disease, like the cyanotic congenital heart disease. And if you like this video, consider subscribing to my channel, and thank you for watching.